Good morning. Um, I will discuss the imaging inputs to diagnose COVID-19 and its complications. So as you all know by now, lungs are the worst affected organ in the body due to COVID-19. So therefore, radiology plays a key role in the imaging and diagnostic workup of these patients. So as you know, the commonest and basic investigation that we use is the common chest X-ray. And if the patient's condition worsens, then they will go on to be investigated with CT studies, where we do what's called a high resolution CT chest. And also, depending on the other clinical conditions, they may need further other imaging investigations like a CT pulmonary angiogram or ultrasound scans or image guided interventions. The third investigation that I have mentioned here is the ultrasound scan of the chest. However, this is not very commonly used, but in the setting where there's no facilities for X-ray or CT, maybe as a bedside test, you can perform it. I'll discuss it later. So why are the lungs worst affected? So if we just go a little bit into the basics, the coronavirus affects its cellular entry via, as you know, attachment of its virion spike protein to the ACE2 receptor. And this ACE2 receptor is commonly found on the alveolar cells of the lung. So taking into account the large number of alveoli within each lung, the virus therefore affects the lungs to a serious, gives serious effects to the lung. And therefore the respiratory system is the commonest affected and the commonest presentation in patients infected by COVID-19. So as I said earlier, apart from the imaging of the lungs, depending on the other clinical conditions, and as Dr. Asuri previously mentioned, with this worsening pandemic situation, there are a lot of patients being admitted who have many other comorbidities. And even with COVID infection, as they progress, previously normal patients also going to develop multi-system involvement. Therefore, depending on their clinical condition, we would investigate them as any other patient with multiple imaging modalities. So, in a COVID-19 patients, when do we perform a basic chest X-ray? So, I must say that we do not use it as a screening investigation because like chest X-ray findings are not specific for COVID-19. It is a viral infection, it's a viral pneumonia, and the imaging gives us an appearance that is suggestive of a viral pneumonia, and therefore just by looking at a chest X-ray you cannot 100% say this is COVID or non-COVID. But however, there is a certain pattern of involvement which may suggest that this is a developing COVID pneumonia. So therefore, it's usually not a screening investigation, and it's performed for known PCR positive COVID patients with chest symptoms to look whether they are developing any evidence of pneumonia. Like I said, sometimes if there is a delay in the COVID-19 diagnostic workup, like the PCR reports are delayed, but the patient is presenting with chest symptoms, in that setting, till the confirmatory reports are available, we can do a chest X-ray and get an idea whether this chest X-ray is suggestive or sometimes typical of COVID-19. Then that will help us in the initial diagnosis. And also, apart from the initial investigation, then those who develop pneumonia will be followed up with X-ray or CT as necessary. And then what about high resolution CT? High resolution CT means very thin cuts of the lungs are taken and they are assessed for various abnormalities. So in other countries, especially developed countries, CT scanners are more widely available, and therefore the threshold for requesting a high resolution CT is low. They will do that even as the initial diagnostic workup. and they can afford to dedicate maybe one machine just for COVID patients, and they have one or several other machines for the non-COVID patients. However, in a country like Sri Lanka, we are a resource poor country, so therefore, in our setting, in our hospitals, CT scanners are limited. Not all hospitals have CT scanners, and therefore, we have to prioritize our investigations. And even if we have a CT scanner, sometimes we have to cater to both COVID and non-COVID patients. Therefore, there's a risk of contamination, there's a risk of cross-infection if proper decontamination is not done. So therefore, we have to think of all that, and with the limited staff, we have to manage. So therefore, in Sri Lanka, we usually tend to start off with the chest X-ray. So as I have said here, sometimes if CT is not available at the particular hospital you are going to work in, then you will need to even transfer the patient to another hospital needing a lot of other things to be arranged. And CT chest will give a higher radiation than a simple chest X-ray, and it's more costly, and as I said earlier, the entire CT room has to be decontaminated, so it's a bit difficult. Whereas as an initial investigation, chest X-ray is much easier to perform. It's very cost effective, and you can do it at the patient's bedside without moving him anywhere. And the mobile X-ray machine is easier to decontaminate compared to the CT suite. So therefore, there are different practices in different hospitals. So some hospitals from COVID patients who are mobile, who are not that ill, they will take the patient to a specially arranged area for the X-ray or any ultrasound to be performed. Yeah. Whereas there are other hospitals where all the chest X-rays or ultrasounds that are needed for COVID patients will be performed as in-ward. Anyway, if the patient is non-mobile or ICU patients, then they have to be performed as in-ward. So that will depend on the local protocol of the hospital you work. Anyway, either way, some of the staff are going to come in contact with these patients. So if it's the patient has to be taken somewhere else, then the ward staff has to get ready and accompany the patient. Or if it's done as in-ward, then the radiology staff will go to the patient. So there is risk for the staff in either way. So I'm just putting in a few facts for you all just to keep in the back of your mind, because as you all also know, unlike the first and second waves of COVID, during this third wave of COVID, with the Delta variant, it is much more infective, and staff getting infected is also becoming a very important fact to consider. So you have to have that also at the back of the mind when you investigate or treat these patients. So during in-ward procedures, you are exposed to many other COVID patients as well at the same time. And then some investigations you have to spend more time, like for example, a simple X-ray would not take much time, but if you were to do a ultrasound guided some interventional procedure, then you will be inside the COVID ward with the patient for a longer duration of time. And also in X-rays, you have to keep in mind that every time you do an in-ward X-ray, not only the patient, but the other patients around to a certain extent, and the radiographer or the other staff are also getting some amount of scatter radiation. We try to keep the patients as far away as possible, but still there is a limitation to that. So all these factors also have to be borne in mind. So that's why I have put this slide to say, please order only when necessary. And reduce risk to staff. But having said that, I must say we are always there to help you in the diagnosis and investigation of these patients, as most of the time a chest X-ray has become a very necessary basic investigation. So how is the chest X-ray performed? I just put this in because you all are just starting your career. So the radiographers, they will wear the PPE and go into the patient and do it. Whenever possible in our unit, we try to do a posterior anterior projection, that is a PA view of the chest X-ray, where the lung expansion is better and the magnification of the heart is less. So what I mean by that is you send the X-ray beam from posterior to the anterior direction of the patient, and the cassette is kept anteriorly. So that is the in those who can stand up, and hold the breath properly, it's always advisable to do it rather than ask them to lie down and do a supine or AP. So, but of course, for ill patients, we have to do either a anteroposterior projection or a supine. But if possible, always try to discuss with your X-ray department and get a PA view, because then you will be able to assess the lungs better. And like I said, it's the first line and sometimes the only available imaging modality. So when do you do it? Of course, it will depend on the physicians or clinicians' request. So usually, from my experience, but we usually do it when either there's a persisting fever or productive cough or shortness of breath, or the saturation levels are low, or else when they are deranged WBC or CRP levels suspicious for a COVID pneumonia or a superarid infection. And as I said earlier, then we do for worsening pneumonia to assess the response to treatment. And also, I haven't added here, but when the patient gets discharged, sometimes we call them back for follow-up X-rays to see whether their fibrosis or changes, pneumonia has settled on. Then looking at the high-resolution CT study, this is actually better for assessing the extent and the degree of lung involvement, as you would all imagine. CT is going to be better, and it's also very important for, say for example, there's a patient who has a normal looking chest X-ray, but his saturation is low. So therefore, then you are in a diagnostic dilemma as to does he have the pneumonia or not. So sometimes, I will discuss later, there are changes in the chest, changes which occur in the lungs, which may not be very obvious on an involved chest X-ray initially. But if you were to do a HRCT, you will get a very clear, you can very clearly assess the degree involved. And also, especially in more severe patients like ICU patients, we will have to do for worsening conditions like organizing pneumonia or pulmonary embolism. Organizing pneumonia or the pneumomediastinum kind of conditions we can see on an HRCT better. And the other investigation we commonly do on these patients, because these COVID patients tend to have a very high sometimes have high D-dimer levels, and the fact that they are very immobilized during this illness and combined with high D-dimers and the thrombotic nature of this illness sometimes needs us to exclude possibility of pulmonary embolism. So therefore, CT pulmonary angiogram is also, I would say, fairly frequently performed in these patients, right? And as I said earlier, there is the possibility of doing an ultrasound of the lungs on a bedside, as a bedside investigations that would give you an idea of the peripheral lung field, whether there are subpleural consolidations or interstitial involvement. Of course, you can't assess all the lungs, the entire lung with the ultrasound, because you will only see the peripheral lung which is close to the probe. It is not very commonly performed. Then just because I added this because you are just starting your career, so chest X-ray doesn't need any preparation apart from proper clothing. An HRCT chest also, it's a non-contrast study, so no preparation needed. Same for ultrasound chest. Then the CT pulmonary angiogram, as with any other study which needs IV contrast medium to be given. So you have to exclude any severe allergies or asthma and pre-medicate if necessary. And if in the ideal setting, a 4-hour fasting would be good. That is just to make sure that if they get a reaction, they don't aspirate anything. But of course, if it's an emergency, you can still do. Then the other important thing is to look for the creatinine level. And if it is deranged, you will need nephrology opinion, because IV contrast can further worsen it and cause renal problems. So therefore, pre and post hydration would be good in any patient going in for a CTPA to make sure that the contrast gets washed out from your body. But if the creatinine is deranged, it's always better to get nephrology opinion regarding certain drugs that can be given. And for a pulmonary angiogram study, we give a high contrast bolus as a pump injection. So therefore, we would like if you can send the patient with a wide bore cannula. When you come to the chest X-ray findings in COVID pneumonia, I have said that 60 to 70% chest X-rays can be normal. This is actually based on some of the studies we did earlier on in this COVID pandemic. But that I must say depends on at what stage the patient is admitted to hospital now. Earlier, last year maybe, most of the all the patients I think were admitted to hospital. So therefore, we saw a lot of normal looking chest X-rays in COVID patients, although they complained of various symptoms. Chest X-rays in up to 60 to 70% were normal. But I suppose now with the worsening pandemic, more patients are at home and they get admitted only when they are symptomatic. These numbers can change. And as I said, normal chest X-ray, normal looking chest X-ray can actually have early changes which may not be seen. The resolution may not show us the very early changes. For example, there is something we describe as ground glass opacities. That's like a hazy kind of opacification of the lung fields due to partial filling of the alveoli by fluid or pus or blood for that matter. So that early ground glass changes sometimes may not be seen on a chest X-ray, which will clearly be seen on HRC. Right? So clinical assessment is very important. So if there's if the chest X-ray appearance does not tally with your clinical condition, with the saturations, then you can always go for a high resolution CT for further assessment. So like I said earlier, so you can get patchy or confluent consolidations, patchy ground glass opacities, and bronchovascular thickenings. So this patchy nature of this ground glass and consolidations are a little bit suggestive of COVID. More than we don't usually see like a segmental or lobar consolidation in these patients. It's more like a bilateral involvement with patchy areas of lung involvement. So usually it's bilateral multilobar. Having said that, we do rarely see patients with unilateral involvement. And usually it starts off in the peripheries of the lung as well as the lung bases, and then as the disease progresses, of course, you see involvement of all zones. And sometimes we see pneumomediastinum, sometimes as a complication of ventilation therapy, but also sometimes rarely we see as a part of the disease itself. But pleural effusion, pneumothorax are rare, and we don't usually see lung nodules or cavities or cysts. So what we see on a chest X-ray is the findings that are consistent with an atypical pneumonia. But in the correct clinical setting and in this pandemic situation, I think if we see that, it can sort of, you can suspect COVID pneumonia. So just a few X-rays. The one on the left looks almost normal, but then there is a little bit of hazy opacification in the left lower zone, and also in the right side chest X-ray there are like very ill-defined hazy opacities in both lungs, which can be suspicious for early ground glass changes. Then when do you repeat the chest X-ray? Like I said, in clinically deteriorating patients or poor response to treatment, or in a stable patient suddenly going into a worsening shortness of breath, you can do it. There is really no standard schedule for imaging. We don't like do 3rd day, 5th day, 7th day or something like that. We will do depending on the clinical situation, and usually if necessary repeat in 48 to 72 hours. So as they progress, you see more defined like patchy consolidations or hazy, like what we call ground glass opacities in both lungs. Here also you see mostly the lower zone involvement and the lung peripheries, and this is gradual worsening situation. So we have what we normally call early stage changes, and then we going to say these are like more in favor of progressive pneumonia changes. This is further progression. Now you can see that not only the periphery, the central lung fields are also getting involved, and it's more extensive and bilateral, multi-lobe involved. So this is just for interest. I've included a few slices from the CT studies. So in the earlier one, you can see this hazy opacification of the lungs, which you can still see the the vascular markings. So it's actually due to partial alveolar filling, what we call ground glass. So usually this is a bit advanced case, but initially you tend to see it more in the lung peripheries and in a patchy nature. But as the disease progresses, it worsens, and you get these diffuse ground glass opacity. Sometimes COVID-induced, you get respiratory ARDS kind of picture, or else non-specific interstitial pneumonitis kind of picture, sometimes secondary to COVID. And then most patients, when they gradually their infections are settling and they are treated, their pneumonia part will also gradually resolve. But however, the chest X-ray appearance will take certain time to resolve. You won't see pneumonia settling in a day or two. So this will progress in few weeks' time. So therefore, these consolidations will gradually resolve with residual interstitial thickening, like what looks like fibrosis-like changes, and then you have to follow them up to see how these changes gradually resolve. So sometimes some patients actually take few weeks to resolve. Some may take months. So we have some patients whom we followed up. So even at 3 months, those who had, these are patients who had, I would say, moderate to severe degree of changes. They will still have some residual fibrosis-like changes in 3 months' time. So we are yet to follow them up further to see how long it takes for these to resolve. We don't image all patients at discharge if they are clinically well. But for those who had pneumonia, like I said, we do follow-up investigation, chest X-ray, and if necessary, CT. So on the left there, it's a patient who had quite severe pneumonia changes, but have almost resolved, and chest X-ray looks fairly satisfactory. But whereas on the left, there is still significant residual changes. So some of the take-home messages I would like to say is, so chest X-ray and high-resolution CT mainly play a vital role in the diagnostic workup of these patients as well as follow-up. And chest X-ray is not a screening tool, therefore you have to take into account the clinical condition and request when necessary. However, it can be a very useful first-line investigation. And this is also very important as you all are going as interns. So even if the chest X-ray looks normal, you have to assess the patient properly. And if you think that the chest X-ray appearance does not tally with the clinical condition, then it's possible that he or she has ground glass involvement, multi-lobe involvement, but which is not very obvious on the X-ray. So then you have to investigate with the HRCT. And also, I would like to kindly request you all to triage and prioritize when requesting investigations. Thank you. Any questions?
There are a few questions, madam, we can discuss. Or...
Yeah, sure.
Yeah. one question is how to differentiate viral pneumonia versus bacterial pneumonia in a chest X-ray.
Normally, this is also a viral pneumonia, so there will be atypical changes. Viral pneumonias, we can see multilobar bilateral involvement usually, whereas a bacterial pneumonia would usually be more of a lobar pneumonia. We would see one particular lobe or a segment being involved, and the rest of the lung would be fairly normal. But this being a viral, this will involve both sides, not symmetrically, but there will be bilateral involvement, whereas bacterial. So even in this COVID patients, sometimes this can start off as a viral pneumonia, as the COVID pneumonia. Then if they get a secondary involvement, so background COVID changes with a particular lobe or particular segment being more severely involved, where we see like not a patchy consolidation, but a more diffuse like a lobar consolidation, then we have to think, is this a secondary bacterial with the background changes of COVID? Is that okay?
Sorry, there's a test called LDA test to detect post-COVID lung damage in private sector. Can you explain this, please?
What was it?
LDA test?
Sorry, I'm not aware of that. I'm not very familiar with that. I'm sorry.
Okay. So next question, can you
classification, but there are sometimes what we do is we classify according to like changes. So one end of the spectrum would be these are normal, no evidence of any COVID like lung changes. Then there are mild degree changes which are really not non-specific, and then we go into say moderate degree like possibly COVID like changes, and then there's the highly suspicious for COVID. And then the other end is the like 5 would be like the PCR positive patients. But this is mainly to, yes, I think in a clinical setting you can use, the radiological department will use these clinical settings to tell you the possibility of this being a COVID pneumonia. In my setting, of course, here we have all COVID positive patients, so we know already that it's COVID. But in a other hospital setting, I suppose the correct specification can be used to sort of give you an idea whether this is not COVID or there's a chance of this being COVID or this is definitely highly suspicious for COVID kind of classification. So it's a different classification, and I don't think at this point I can go into all the details, but so depending on the findings, they divide them into these different categories to see how much of a possibility it is to call this is highly suspicious or not. So there are classifications currents being the common views.
Right. Next question is, madam, if following completion of 14 days treatment, a patient with SOB continuously, do we need to do chest X-ray?
Sorry, after 14 days, if they continue to have SOB?
Total SOB, yeah.
Yes, so SOB means you have to have a like a optimal way of assessing that. So just SOB is very subjective. So if they have low saturation, definitely. If with exertion the saturation is going down, then I think even in the absence of fever or usually they might have a cough if they have a pneumonia, but even if not, if the saturation is low, definitely yes. I think they have to be investigated with the chest X-ray. But just SOB per se, it's very subjective. Some people, continue to have this mild shortness of breath when walking, or but if the saturation is maintained, then I don't think you need it. But then I think this is decision of the physician with regard to the other investigations as
well. Right. I think that, madam, that LDA test that's for renal lymphocyte detection test. I think that's for done for renal transplant patients. I think I'm not sure whether they are referring to this. Yeah. Madam, is there a place for contrast enhanced CT?
Just yes. So like I said, so usually we do the non-contrast high resolution CT just to look for the pneumonia. But for anything else, like if you suspect a pulmonary embolism, the CT pulmonary angiogram is a contrast study. Like I said, I gave the preparation how to prepare and all. So CT pulmonary angiogram is with IV contrast, and like earlier discussed, so many patients have other complications, other comorbidities, which sometimes patients with other known cancers come in. Otherwise, patients who are suspected to have venous sinus thrombosis come in. So, like different settings, then we have to do contrast studies for to detect those particular complications or the other comorbidities. Definitely, we do a lot of contrast studies in COVID. But if it's just pure COVID pneumonia, then we can just do a high resolution CT just to assess that. But anything beyond with any other complications, yes, we have to give IV contrast.
Right. Last question, madam. How after severe COVID pneumonia, within how many days, how many weeks the patient will get fibrosis?
So usually, now what we described as these early changes, which are mainly the ground, what I said, kind of ground glass changes, are within the first few days of the illness. And then going into the second week, they develop these consolidations associated with the ground glass, and there's a little bit of interstitial edema thickening during that stage. And then going beyond 14 days, like into the third week or fourth week of illness, provided they are clinically improving, their consolidations tend to resolve. But this interstitial thickening or like fibrosis-like changes tend to stay on in the third and fourth weeks, and they are very slow in gradually resolving. So why I said fibrosis-like is also that, because I don't want to label them as fibrosis, not knowing whether they will permanently have this or not. But these changes, from our experience so far with these patients, they tend to resolve very slowly, but there is a possibility that some of these interstitial thickenings will persist as fibrosis. So that we have to yet to see the follow-up studies and decide like how long it takes to fully clear, or whether they are actually permanent, these changes. But up to third week, fourth week, we see these changes. And many patients, when they come back for their follow-up 6 weeks after discharge also, they still have a certain degree of changes. That means they are very slowly only resolving. So not all patients, those who had a fair degree of pneumonia, will beyond the fourth week also have these changes. And to my experience, up to 6 weeks also they have had these changes. So these we have to yet to follow up these patients in the long term to see when, at which stage, if at all they resolve, and how they how long they will have these changes.
Right. That's comes to end of this lecture by Dr. Kishani Abeyewardena, consultant radiologist at IDH. Right. Thank you very much, madam, for that in-depth analysis description of COVID and pneumonia radiological diagnosis. Right. Next up is medical legal aspect in the clinical management of COVID-19 and importance of knowing how to manage COVID dead bodies by Dr. Channa Pereira, Senior Consultant JMO at IDH. Over to you, sir. So can you hear? So give us a few moments, he will start sharing slides. So your mic is muted, right? Right. Need to make it full screen, sir. Right. We can't hear you yet. So we can see you, can't hear you. Your mic is unmuted but can't hear the voice.
Can you hear me now?
Yes, sir. Loud and clear, yes.
Yeah. So what I will do is I will use my phone to talk to you, but you will use the laptop to show the presentation. That's all right, right?
Yeah, excellent. Yeah.
Okay. So I'm going to talk on the medico-legal aspects of practice in context of COVID-19. That is the topic. This is mainly targeted for the pre-internees. Can you tell me how to move the... Right. So, in brief, when it comes to forensic medicine, there are two aspects, the clinical forensic medicine and postmortem examinations. Here, we are going to mainly talk on the management of death in context of COVID-19. First of all, when there's a death, in general, whatever the kind of death, you should certify the death in the ward or in the ICU. So, the way to certify death is when you're called by the nurses that there's a death. So, you have to feel for pulse and check for blood pressure, and certainly they will not be recordable. And you have to check for spontaneous breathing, whether the patient has spontaneous breathing. That is very important, since the patient may be fixed to a ventilator if the patient is in the ICU, which I will discuss later. So if there's no spontaneous breathing, if the patient is not fixed to a ventilator, then you check for pupillary reactions by using a torch, whether the pupils react to light or not. If they are not reacting, so you write all these parameters that you checked: no pulse, no blood pressure, and so blood pressure is unrecordable. There's no spontaneous breathing, pupils fixed and dilated, and pupils are not reacting to light. And then you certify death by putting the date and time, and then place your signature. If the death has occurred in an ICU, when the patient is fixed to a ventilator, certainly patient is fixed to monitors as well, then it's going to be easier for you to certify death. But if the condition is a brain death condition, then of course there's a different methodology of certifying death. Then according to the Transplantation Act number 48 of 1987, it's specified how to certify a brain death. Then of course you have to check for gag reflexes, vestibulo ocular reflexes and so forth, apart from these parameters that we check for. But normally what you have to do is the ordinary certification of death, as I mentioned here, and then if the patient is fixed to the ventilator, not in a brain death situation, by using these parameters of the monitors. And the other question is whether it's important or whether it's relevant to keep this dead body for 2 hours in the ward or the OPD. Now, as you know, we have a practice of keeping these bodies for 2 hours in the ward or at the OPD. The reason is, in 2 hours, you get onset of rigor mortis, that is postmortem stiffening of the dead body. So, by 2 hours, you have the postmortem stiffening of the facial muscles, neck muscles, and you will get stiffening of those muscles, and then you are certain that this person is dead, because you don't get postmortem rigor mortis in a living person, even in persons of brain death. So that's why we keep these bodies for 2 hours. But certainly, if the patient is fixed to monitors, then of course you are certain that the person is dead. So in context of COVID-19, we don't recommend to keep these bodies for 2 hours, especially because if the patient is in the ICU or HDU, that bed may be required to save the patient of to save the life of another patient. So it is not a must for you to keep these dead bodies for 2 hours, but you should make sure that you are certain of certification of death. If you can recall your memories of 6 months back, there was an incident where there was a person, even in Sri Lanka, in General Hospital Negombo. A dead body was sent to the morgue, and from the morgue, the patient stood up from the trolley and walked out. So these conditions occur due to the condition called suspended animation. Suspended animation is different to death, certainly. It is different to brain death as well. In suspended animation, what you have is, you have all the physiological functions at a very low rate. So you may not be able to see the person breathing unless you keep a mirror closer to the nose, where you can see the breathing, and if you check for pulse, you will not be able to record pulse, neither blood pressure. But the important thing is, if you use the torch and check for reflexes of the pupils, that will react. So that's why it's important to check for pupil reactions as well. But in context of brain death, it is irreversible. Whereas in suspended animation, there's no brain death. So the physiological functions are occurring at a very lower level, where maybe severe acute poisoning, maybe hypoglycemia, maybe snake bites. It could be anything. And so the patient is not dead, and he will, once he regain consciousness, certainly he may live for another 50 or 60 years. So that's why you have to importantly check for reflexes of the pupils. And that is the concept of keeping these dead bodies for 2 hours. So in the ward or at the OPD, if you are not certain that the person is dead, yes, why not keep the body for 2 hours? But it is not mandatory, especially in the context of COVID-19. Now then, when there's a death, if the death is due to a natural cause, such as COVID-19, if you diagnose COVID-19, then of course an inquest is not required. An inquest is required only if the manner of death is natural and if the cause of death cannot be formulated, or if the manner of death is unnatural, such as accidents, suicides and homicides. But there are certain natural deaths where the cause of death is also known, which requires an inquest. Now, if you take the mental hospital, if a death occurs as a natural cause, still it requires a mandatory inquest by virtue of the hospital being a mental hospital. So, if the death occurs in under custody, police custody, leprosy hospital, mental hospital, then of course, even if the death is natural, it requires mandatory inquest, not only by an inquirer, by a magistrate. Because now, when there's an inquest, the inquiry into sudden death can hold the inquiries in benign. Yeah.
So your co-hosted, sir? Chan, sir, can you hear? So your the phone is co-hosted, so you can, it's unmuted, can you speak, sir?
Yeah, can you hear me now?
Yes, sir, can you? Yes.
So, an inquest can be held by the magistrate or the inquirer in sudden death, and certainly the inquirer can hold only in benign cases. Now, if a death is of natural nature, as I told you, in COVID deaths, an inquest is not required, but certainly if it's unnatural, the inquest is required, because people may die due to road traffic accidents where the persons are positive for COVID-19. So now, if now we'll take a situation, because all these circulars were changed recently. When a death occurs, whether at home, en route to hospital, or in a healthcare institution, if the body is coming from a high risk or lockdown area, it requires a mandatory PCR test. Now, earlier, at the initial stages of the pandemic, the high risk and lockdown areas were limited to Colombo. Then it spread to Western Province and subsequently now the whole country is a high risk area. So we were compelled to perform PCRs in almost all these dead bodies, which became a real problem regarding disposal and also which became unwanted. So we changed the circulars. Now if a death occurs, hello? Yeah. Now, if there's a home death, you don't have to send the body to the hospital for a PCR if the coroner is not suspicious of the dead body being infected with COVID-19. Then the coroner can give an apparent cause of death and dispose the body. But the body must, from residence, to go for disposal to the crematorium for cremation or burial. Both cremation and burial is permitted if it's not suspicious of COVID-19. Even if it's suspicious of COVID-19, the home death, then of course the coroner should send the body to a hospital to perform a PCR. If the PCR is positive, it should be treated as a COVID death. If it's negative, then of course routine disposal. So if it's going to be positive, upon the post-mortem examination, the JMO gives the cause of death, and according to the wishes of the relatives, either it can be cremated or buried. If it's going to be buried, certainly still it is permitted only in designated burial sites earmarked by the government. Right. I discussed this already. So if a death occurs in a ward, how to treat a dead body? Certainly, the nurses used to pack the orifices with disinfectants, and it is not required. It is not advised to pack these dead bodies with disinfectants if a post-mortem examination is required, especially if a post-mortem PCR is required. So what you should do is place the dead body as it is in a clean body bag and send to the morgue without packing the orifices or treating the dead body with PCL or sodium hypochlorite or any other disinfectant. And even in the ward, it's the same. If the person is undiagnosed of COVID-19, then of course we have to perform a PCR, so the dead body should not be treated with disinfectants. Now, from the ward, the body is taken by the morgue staff to the mortuary, and then the necessary things will be performed, and whether it's a post-mortem or not. As I told you, the disposal is by cremation or burial. And now, in a ward death, if it's a natural death, the ward doctor should give the cause of death as natural and certify, give the proper cause of death. And if it's going to be natural, the ward doctors can write the declaration of death form, which is called the B33 form, and you have to write the place of disposal, because there's no right place to write the place of disposal in the declaration of death form. Now, with this declaration of death form, earlier the relatives should have gone to the Registrar of Birth and Death for registration, which is not required during the context of COVID-19 before the body is disposed, but the body can be, so the relatives can get this body death registered within 45 days after death. Right. Now, in COVID bodies, the bodies are not handed over to relatives. So the bodies from the ward, from the hospital, it's handed over to the PHI, MOH and the police, and the necessary disposal is performed according to the guidelines. The most important thing is how the cause of death should be written. Now, cause of death has to be written according to this format. 1A is the immediate cause of death, 1B is the antecedent cause of death, and 1C is the underlying cause. And 2 is for associated and contributory causes. I'll give you some examples now. If a person dies as a result of septicemia, due to pneumonia, due to COVID-19 infection, in 1A, you write septicemia. 1B, pneumonia. 1C is COVID-19 infection. So COVID-19 infection has caused pneumonia. Pneumonia has caused sepsis or septicemia. But it's not mandatory for you to get sepsis, pneumonia for you to die. So in that case, of course, if there's no sepsis, 1A is going to be pneumonia, 1B is going to be COVID-19 infection. There will not be a 1C. And also, as you know, there's an increased clotting ability of blood in COVID-19, a hypercoagulable state. So people who get infected with COVID-19 may die as a result of pulmonary thromboembolism due to deep vein thrombosis. Then of course 1A is the immediate cause, that is the acute pulmonary thromboembolism, which occurred due to 1B, that is due to deep vein thrombosis, and C is going to be COVID-19 infection. COVID-19 infection has caused deep vein thrombosis. Deep vein thrombosis has caused COVID-19 as the acute pulmonary thromboembolism. So what are the associated and contributory causes? If the patient was suffering from hypertension, diabetes, bronchial asthma, obesity, etc., then you write those conditions in 2. Right? So, in COVID, people died directly due to COVID infection as a result of pneumonia, COVID pneumonia, or deep vein thrombosis causing pulmonary thromboembolism. But certainly, people who have, these are the examples that I mentioned, right? So people may die due to heart attacks as well. Person who has ischemic heart disease may develop an acute coronary syndrome, or in autopsies we give the cause of death as coronary artery atherosclerosis or atherosclerotic heart disease. So ischemic heart disease condition. In these conditions, people die as a result of an ischemic heart disease or acute myocardial infarction, but he was infected with COVID-19. So COVID-19 infection comes in 2 now. Unlike the previous situation, in previous situation, COVID-19 infection was the underlying cause. Here, it's going to be just a contributory cause. Like this. So it's not a direct cause. COVID-19 is not going to be a direct cause for acute myocardial infarction, but may have contributed. So these are some of the examples. Now, people may die due to sepsis due to acute pyelonephritis. And COVID-19 infection could be just an incidental finding or contributory or associated finding. So the topmost cause of death is the cause of death that we performed, the very first autopsy that we performed in Sri Lanka. I performed that autopsy on 5th of May 2020, last year. The person did not die as a result of COVID-19 infection as a direct cause, but died due to sepsis, due to acute pyelonephritis, but treated for COVID-19 infection. So 2 was COVID-19 infection. And people may die as a result of pulmonary TB. If they are infected with COVID-19, 2 is going to be COVID-19 infection. So these are some. Hello. Right. Sorry. Now, how to fill the declaration of death form is, I think you should be. There's a form in the ward. There's a book in the ward where you have to fill that book. So PCR versus rat in dead bodies. We don't encourage to perform rat in dead bodies. Even if you perform, if it's going to be positive, we take it as a positive result. But even if it's going to be negative, we are compelled to go for a PCR. Now that is basically what I wanted to discuss in context of dead bodies. The next is of course clinical examination, which is not very relevant in context of COVID-19, but forensically we examine patients for medical legal purposes under medical legal examination form or a magistrate order. And if we examine patients who are infected with COVID-19, we have to take special precautions. And that is my presentation. If you have any questions, you can ask. Any questions? Right. So there's a question how to differentiate a normal death and a brain death. So normal death, as I told you, it's certified based on the absence of pulse, absence of recordable blood pressure, absence of spontaneous breathing, and absence of pupils, non-reacting pupils to light. So that's why you write there, no pulse, blood pressure unrecordable, that's no spontaneous breathing, pupils fixed and dilated, and pupils are not reacting to light. But certainly there are exceptions. If you take OP poisoning, organophosphorus poisoning, the pupils will not be dilated, they will be constricted and they will not react to light. Now in brain death situation, there is beating heart, because synonyms for brain death is beating heart cadaver, right? So beating heart cadaver is a dead body where the heart is still beating. So heart is beating, person is fixed to a ventilator and mechanical ventilation. If you take the tube out or if you disconnect from the ventilator, the person will die as a result of hypoxia, because the brain dead people cannot spontaneously breathe, but they have spontaneous heartbeat, as you know. So the way to certify brain death is totally different system, where if the brain dead person is going to be, if his organs are going to be harvested for transplantation, certification of death should not be performed by persons who are involved in the transplantation team, including surgeons, including coordinating doctors, including anesthetists. It should be by two. It was only for consultants, but now two medical officers who does not have a vested interest in this case can certify death. How to certify death? Now the person is fixed to the ventilator. So apart from the normal things, you have to check for vestibulo ocular reflex. How do you do that? So you put some cold substance such as ice in the ear, and so that's how it occurs, the ocular reflex. If the brain is dead, the vestibular ocular reflex will be absent. And gag reflex, you put the tongue depressor into the throat, and absence of gag reflex will be supportive of brain death. And the apneic test. So you hypoxygenate the patient and disconnect for a short period, and then you check whether they are spontaneous breathing, because now you have to hypoxygenate the patient. Then when you disconnect, the carbon dioxide level of the blood is going to increase. Carbon dioxide could stimulate the respiratory centers if the patient is not brain dead. But this apneic test will be negative if it's brain dead condition, because brainstem is already dead. And this apneic test has to be repeated in half an hour's time. So brain death certification, unlike the normal somatic death, has to be repeated after half an hour, and then only you can certify the brain death condition. And also I must tell you, in brain death, as I told you now, in 2 hours after death, after somatic death, normal death, you get onset of rigor mortis. But in brain death, that will not happen, because still, apart from the brain, all the other things are functioning. If you put food into the stomach through an NG tube, it will get digested. There will be digestion, filtration of urine and circulation, everything happens. So there will not be rigor mortis upon brain death. Any other questions? I mean, the moderator can read the questions if there are any. It's one of the questions that I read. Any other questions? I think there are some other questions which were put forward.
Yeah. As in the chat box, there are few questions.
Yeah. Please read it if there's time.
Yeah. Sir, what is the possibility of a dead COVID body acting as a source of COVID infection?
Right. This is the question. Now, dying patients with a low CT value has a high viral low CT value. Now, for example, if you take CT value around 12, they have a lot of viruses in their body. So soon after death, these viruses does not die. They will not die. So they are still present in the dead body. That's why, if the body is not required for a PCR, postmortem PCR or a postmortem, we treat the dead body with disinfectants, because surface will have viruses. But certainly this dead body, upon death, they will not breathe. So there will not be aerosol generation, which we normally speak, from a living patient, from a dead body. But the problem is, since the virus is there in the lungs and in internal organs, when you do not handle this dead body properly, especially during autopsies, still there could be a higher viral load, especially in the airway. So that's why you have to take precautions, and the virus tend to die with time. Certainly, if the body is decomposed, the possibility of somebody getting infected from a decomposed body is, I would say, I can't say almost zero, but it's very much less, because when the body is decomposed, when the cells are getting decomposed of the host, the viruses will die.
Okay, sir. Then there's another one. Can you please show those slides? Oh, I think they request the explanation on how to fill the course of death examples.
Yeah, I will explain you. Can we go back to this presentation again? Cause of death. Cause of death is formulated according to a specific standard format internationally. So that's 1A, 1B, 1C, and then you have 2. So 2 is denoted for associated and contributory causes. That means in 1 you write the actual cause which led to death with the sequelae of events. Now I'll give you a small example. If somebody will be knocked down by a vehicle, or we'll say assaulted on the head and developing a head injury, right? So as a result of head injury, the patient will develop cerebral edema. Cerebral edema is going to be the immediate cause. So 1A will be cerebral edema, 1B will be head injury. It may be an extradural hemorrhage, cerebral contusions, intraventricular hemorrhages, acute subdural hemorrhage. So 1A is going to be cerebral edema, 1B is going to be head injury, 1C is going to be blunt impact trauma to the head. So blunt impact trauma to the head due to assault has caused, that is C, 1C has caused 1B, which is the head injury. So as a result of the head injury, there was swelling of the brain which caused the death. So there should be sequelae of events. So 1A should occur as a result of 1B, 1B should occur as a result of 1C. So that means 1C has caused 1B, 1B has caused 1A. So in COVID, as I told you, if the patient is developing sepsis, and if the sepsis is due to pneumonia, if the pneumonia is due to COVID-19 infection, 1A is sepsis, 1B is pneumonia, 1C is COVID-19 infection. That means 1C, that is the COVID-19 infection, has caused 1B, that is pneumonia. So 1B has caused 1A, that is pneumonia has caused sepsis. And if you take this deep vein thrombosis, so acute pulmonary thromboembolism has occurred as a result of deep vein thrombosis, that is 1B. Deep vein thrombosis has resulted due to COVID-19 infection. So that means 1C, COVID-19. Hello? Yeah. So COVID-19 infection due to its hypercoagulable state has caused 1B, that is deep vein thrombosis. So deep vein thrombosis, that is 1B, has caused acute pulmonary thromboembolism, which is the immediate cause, 1A. And if the patient was having dehydration, you can write dehydration in 2. If the patient was having ischemic heart disease, you can write ischemic heart disease in 2. If the patient has CKD, you can write CKD in 2.
Okay. One other question. If the number of COVID deaths are very high, can COVID dead bodies disposed without an autopsy?
Yes. We don't do autopsies in all COVID deaths. Because now, I perform a lot of COVID autopsies. I have performed over 100 autopsies, but to all those deaths, I'm attached to 3 hospitals, IDH, Pulmonary and National Institute of Mental Health. But these autopsies that I have performed were less from these 3 hospitals. Though most of these COVID deaths initially occurred at IDH and Pulmonary because these were the initial clinically treated hospitals, but now there are other hospitals as well. So we perform an autopsy in a COVID death only if it requires judicial inquiry and inquest. We don't do autopsies in all COVID deaths.
Then another one, can you please explain home death management?
Yeah, home death management, I think I told you. Currently, it's like this. Earlier, we did PCRs for all home deaths. But now, if there's a death occurred at home, the relatives need to inform the Grama Sevaka. Grama Sevaka, upon arriving at the place of death, if he can give an apparent cause and if he excludes COVID, how the COVID is excluded is a different matter. Because we have instructed them how to do that. Exclude COVID. If he has an apparent cause, he can release the body. And similarly, if the Grama Sevaka is reluctant, the relatives need to inform the police, who will subsequently inform the coroner, the inquiry into sudden death. He will visit the place, and if he excludes this as a COVID autopsy, then of course he can give an apparent cause and get this dead body released without a postmortem. But if the coroner thinks, or if the Grama Sevaka thinks that this body may be infected with COVID-19, then of course they are compelled to send these bodies to hospital to perform a PCR. Upon performing the PCR, if it's positive, it is considered as a COVID death. If it's negative, non-COVID. Now the dead bodies which are being released by the Grama Sevakas or the coroners without sending to the hospital, that means excluded COVID deaths, still the dead body should not go to a funeral parlor or intermediate places. The dead body should be disposed within 24 hours of death, of certification or death, and the body should be taken from residence to the cemetery for cremation or burial.
Okay, so there was a sort of a ethical questions is asked. Then ICU, if all the beds are occupied and young patient whose life can be saved needs an ICU bed, can we replace a near-death patient with this one? And then what is the legal background? This is a sort of ethical dilemma this person is asking.
It's a long question. Can you just summarize?
Yeah, one thing is that there is a young patient whose life can be saved, and there is an ICU bed with a near-death patient. Can we replace this near-death patient with the young patient?
No, you can't.
What is the legal background, he's asked?
No, you can't, because
Yes.
that will amount to euthanasia.
Yes.
If you disconnect the ventilator from a living patient, whether the patient is 105 years or 110 years, right? If the patient is not brain dead, if it's brain dead, yes. If it's not, you cannot. And if you do that, you'll be liable for killing that patient by euthanasia. Euthanasia is mercy killing.
Yes. Then one, I will limit to two questions. Maternal deaths need, all maternal deaths require an inquest, no?
All maternal deaths requires mandatory inquest and mandatory postmortems.
Then one other thing, what is the role of PHI in home deaths?
Yeah. Now, in home deaths, earlier PHIs had a major role to play because they should have excluded that this death is not suspicious of COVID. But now still, the information by the Grama Sevakas and the inquirers should obtain from the MOH and PHIs whether this area of death is not suspicious of COVID-19, because they are the people who decide on that, right? So PHIs and MOHs should give the clearance that, for example, this area where the death occurred is not suspicious of COVID-19.
Okay, that's all I think. Dr. Roshan, are you here? If not, Roshan?
Now we are going for, thank you very much, Dr. Channapaya, Senior Consultant JMO at IDH. Thank you very much for that in-depth description of all the that's related to COVID postmortem, sir. Thank you once again, sir. So we are now going to take a lunch break. So we are going for the last lecture for the today. That's by Dr. Damayanti Dampitia, Senior Consultant Physician at IDH. It's on a case discussion. I think she's logged in. Dr. Ahmed, are you there? So give us a moment until they come online. Just to remind you, we have a session tomorrow. That's another important part of this infectious control. That is infectious control oversight and by lecture given by consultant microbiologist. And it will start tomorrow 9 a.m. Please note 9 a.m. Not at 8. So please log in by 9 a.m. And plus another very important for you all is that's PEP, protective equipment, how to put on and how to remove, that is called donning and doping. So please make sure that you participate tomorrow as well. We start at 9 a.m. tomorrow and it will be over by 11, short session. So please convey to your colleagues, those who didn't join today. But then you can start. So next Monday we are having, you will send an email. So Monday we are having emergency medicine on Monday and Tuesday. That started at 1 p.m. to 4 p.m. And the last lecture will be on 17th of September. That's our surgery, full day session. Then that's all the sessions. Then we will send an email of the MCQs that you will have to answer. Right. Madam, can you hear? Right. Over to you, madam. You can start. Okay. Yeah. So, Tom, if you can start. You can hear now? Can you hear? Yes, loud and clear. All right. Okay. Are you sharing? Can you see the screen? Not yet. Not yet. share. Can you see now screen now?
Yes, can see, yes.
Okay, okay.
Good afternoon. Can you see the screen now?
Yes, madam, can see, yes.
Okay. Okay. So I'm going to discuss few short cases with regard to COVID-19. First case is a 47-year-old male admitted with headache, fever and sore throat for 5 days. He works in a pharmacy and COVID PCR done 2 days back and received the report today. So basically this patient is a 47-year-old male with a history suggestive of COVID infection for 5 days and actually positive PCR. Now my first question is, how do you perform an initial assessment to triage this patient? Now when you have a patient who is having COVID infection, our problem is whether this patient needs any urgent intervention. That means whether this patient is desaturating, what we have to do now to see. Now, as you know, COVID patients, when you go near the COVID patients, we have to get dressed with our PPE and go. But certain things we can see from the distance, so we have to include those things as well. So how do you perform an initial assessment? What are the important things? Can somebody answer? What are the things you look for in this patient? Okay, basically what we have to do is whether there are any respiratory symptoms, cough and shortness of breath. Usually if they are desaturating, they usually have the respiratory symptoms. And we can see whether this patient is dyspneic or cyanosed. And we can see the breathing pattern. Even we can see it from the distance, whether the patient is breathing fast or whether there's any labored breathing. And see whether the patient is using any accessory muscles. And when he talks, we know whether he can complete a full sentence or not. And then we can see whether the nasal flaring is there. And we have to assess whether this patient is agitated, confused or uncooperative. And the main important examination points we have to assess: pulse, blood pressure, respiratory rate and SpO2. The definition of severe pneumonia is the fever or suspected respiratory infection, that means cough or SOB, plus one of the followings: respiratory rate more than 30 breaths per minute, and severe respiratory distress, or SpO2 less than 90. So if patient has one of these things plus respiratory tract infections, so we call it as severe pneumonia. So if there's evidence of severe pneumonia, of course we have to manage accordingly. So then we have to try this patient as an emergency case, and we have to act accordingly. But if this patient does not have any evidence of pneumonia, then we have to see whether this patient has any risk factors for severe pneumonia. Right? So what are the risk factors for severe pneumonia in COVID? Can someone answer?
Diabetes.
Yes, yes. What are the, yes, diabetes. Anything else?
Obesity.
Obesity, yes, very good. Anything else? So it's very important when you are assessing a patient. Now, yes. So we are having home-based care as well these days, right? So we have to select the proper patient for the home-based care, right? So we have to select the patients who are not having any risk factors for home-based care. So you have to know who are the patients can be sent home for home-based care, or who are the patients who need admission. So the risk factors we consider for severe COVID, all the patients, that means age more than 65 years, and the patients who are having comorbidities. The important comorbidities are cardiovascular diseases, diabetes, as you have mentioned, and the chronic respiratory diseases. It can be either COPD or moderate to severe bronchial asthma, fibrotic lung diseases, interstitial lung diseases. So those things, on top of these things, if patient get COVID pneumonia, the condition can become worse. And the chronic kidney diseases, and the patients who are immunocompromised, that means patients who are on chemotherapy, radiotherapy for cancers, or patients who are on transplant for care, like immunosuppressants therapies, or some chronic immunosuppression conditions who are on long-term prednisolone, right? So those are the people can get severe disease. And as you mentioned, obesity is again is a very much important risk factor, because when we see the patients who are going to the ICU and the patients who die, majority of them are obese, right? So that's very important. And pregnant females, again, they can get severe disease, and the smokers, again, they can get severe disease. So what are the infection control methods you use for this patient? Now this patient is a COVID positive patient, so probably you will be having infection control methods tomorrow. So I'll just go through what are the important points. So the things, when we talk about infection control methods, you have to, first thing is we have to isolate this patient, right? So you know that patient is a positive patient, so you have to isolate. So the isolation should be done in a single room with good ventilation, if possible, right? But as now we are having a lot of patients, so we can't do it. So what we can do is we can have a cohort ventilation with other positive patients. So that's what we do in these days. We are having separate COVID wards where COVID patients are kept together. And in a ward, if we are suspecting a patient is having COVID, so then of course what we can do is we can like keep a distance, right? At least 1 to 2 meter distance between patients. And we have to provide the medical mask for the patient. So that is again important, right? Because if the patient cough or talk, right, then there's a high risk of spreading the infection. And you have to provide tissues for the patient to cough. Cough fatigue should be practiced. And hand hygiene again for patient as well as the staff, very important, right? And when you are going closer to a patient who is non-positive, then you have to wear PPE, adequate PPE, right? Then notification is again important in this patient. Okay, so we'll move on to the second case. This patient, again 48-year-old male. He admitted with fever for 7 days, cough, SOB, and left-sided pleuritic chest pain for 2 days. He was tested positive for COVID 3 days back, and he's a diabetic on metformin SR 500 BD. So how do you do a quick assessment? Right? So what are the important points here? As we mentioned earlier, so this patient, of course, what you can see is he's a diabetic, so he is having some risk factors. And in addition, this is like he has symptoms for 7 days. Usually what we see, they develop pneumonia in the second week. Now with this Delta variant, you can see around day 5, 6 also patients developing pneumonia, but usually it's the 7th day, 8th day, 9th day, you can see the patients becoming critical with COVID pneumonia. So the important points actually as we discussed earlier, right? As we discussed for the first patient, we have to like the respiratory symptoms, cough, SOB, whether patient is dyspneic or sinus, and again the fast breathing, labored breathing, whether patient is using any accessory muscles, and to see whether he can complete a full sentence, nasal flaring, agitated, confused, those things we have to look for. And the pulse, blood pressure, respiratory rate, and the saturation, very important. So when you examine this patient, he is tachypnic, but he is not cyanose, and he is unable to complete one sentence. He is using his accessory muscles, and he is having high temperature 103, tachycardic pulse of 134, BP is normal, a bit high, respiratory rate is high, and SpO2 84. Right? So he is on air, right? So he is tachypnic, desaturated, tachycardic, having high fever, and the respiratory rate is high, saturation is low. So how do you manage this patient? So what are the important points you want to consider? Can somebody answer? What are the most important points what are the things you have to do immediately? If a patient is not cyanose really, but tachypnic and the SpO2 is 84, what is the most important thing? Okay, we give the investigations as well. WBC 11.2, HB 15, platelet 159, CRP 188, creatinine bit high 148, ASTLT again little bit high, CBS 390. So how do you manage this patient basically? What are the important things you have to do? You could gun the pen. You know, check what's don't find the cuts. Again, another way.
No, little bit. The oxygen is
Like, if you can have another computer, you can. When you fill up generator, even my phone is okay. Phone is okay?
phone doesn't. They have no
I have. Yes, I have seen some answers in the chat box. Majority of you are talking about oxygen. Yes, patient is
this one or this one? This one.
Yeah.
Let's see from that.
Yeah, no, we'll get this. Make up here and go. Okay, we go to the
presentation.
yeah. Right, okay. So And this is his chest X-ray. So the most important things here, oxygen is needed, yes, right? So depending on the patient's now, when should you start oxygen for a COVID-19 patient? What should be the target level? It should be less than 94. If the patient's saturation is less than 94, we should start on oxygen. So this patient saturation is quite low, so we have to start on oxygen, right? 84% on room air, right? So we have to start on oxygen. There's no question about that. Then we have to like keep the oxygen saturation more than 94, right? So we have to increase the oxygen to keep it more than 94. And in addition, now maybe creatinine is bit low, bit high, so maybe patient is maybe little bit of dehydration is there, blood sugars are high, so we have to consider insulin and dehydration for this patient as well, right? So this is this patient's chest X-ray. Can you see the, now this is a typical chest X-ray of a COVID patient, right? So if you can see, there are like peripheral consolidation. What you can see is the shadows are there towards the periphery of the lungs, usually is bilateral, and if you see the like upper part and the middle part, that's quite clear, right? So this is the chest X-ray of this patient, which confirms pneumonia in this patient. So he was started on oxygen 10 liters per minute. 15 minutes later, his BP is like same like earlier, 138/98, pulse 130. Respiratory rate is still 42, SpO2 88 on 10 liters of oxygen. Now what can you do? Mungkin kan ada. Pakai link ke mana ada?
Listen.
Ini.
Yes, I know.
Okay, target saturation is usually more than 92 we have to keep, but we are not going to like go beyond, like we are not going to go for 100%, 98% saturation. Above 94 it should be okay, right? Right. So we have to increase the oxygen. Yes, as you have mentioned here, we have to increase the oxygen to 15 liters and CR. So it's important, and at the same time, so if we are increasing it to 15 liters, then of course face mask will not be adequate. Face mask is not adequate, then you may have to go for NRBM, right? Okay, so this patient escalated the oxygen therapy to 15 liters per minute with NRBM. After half an hour, blood pressure is 134/84, pulse still bit high, respiratory rate 34, now it has come down, SpO2 95. So what should you do next? What's happening? Recording in progress.
No. Okay.
I think now only I have joined.
Yeah.
So, right. So what you have to do is we have to keep. So what we can do is we can just so we have to keep the SpO2 like this, right? 90 above 94. So then we can continue oxygen 15 liters per minute with NRBM, and depending on the patient situation, we have to monitor this patient. Then if the saturation drops further, then of course we have to escalate further, right? So we can't go further with our normal oxygen NRBM. Then of course you have to go for high flow CPAP beyond this point. Or if patient is okay, then of course you can gradually reduces the oxygen treatment. Okay, we'll move on to the next case. It's a 35-year-old male, COVID PCR positive. He was transferred from local hospital due to low blood pressure, 80/60. He got admitted to local hospital 2 days back with a history of fever for 3 days, arthralgia and myalgia. No cough, cold, sore throat, vomiting or loose motion. So this is a 35-year-old male, positive PCR report, admitted due to high fever, arthralgia and myalgia, and his blood pressure is low. So that's why patient was transferred to our hospital, right? He does not have much respiratory symptoms. So on examination, he was afebrile and he was ill looking. He was tachycardic with low volume pulse, blood pressure 80/60, respirator at 24, SpO2 99 on room air, lungs clear, abdomen soft, and there's liver tenderness. So what is your differential diagnosis for this patient? Can somebody answer, please?
Dengue fever, madam?
Okay, right. Yes. Yes, very good. Right? So you have to consider other things as well. Right? Because now you can get a patient who is having now, as you know, now when a patient gets admitted for some other condition, when you do a PCR, it becomes positive. Right? It doesn't mean that patient is having symptomatic COVID. So COVID may be asymptomatic. Majority of COVID patients are asymptomatic. So you have to consider other differential diagnosis as well. So if anybody is having fever these days, usually we do a PCR, right? But it does not mean that the patient's like illness or condition is purely due to COVID, right? So you have to consider other things as well, right? So actually this patient, so the reports available, so we have to consider other differential diagnosis as well. So the available reports done at local hospital on the previous day, WBC 3.2, hematocrit 39, platelet 106, CRP 2.1, creatinine normal, AST/ALT bit high. Right? So if you can see here, the counts WBC is bit low, platelet is bit low, but it can occur due to COVID as well. And AST/ALT bit high, again it can be due to COVID, but still you have to consider other diagnosis as well. So what are the important steps in the management of this patient? What are the urgent investigations you order for him? So can somebody answer? So can somebody answer? Yeah. Okay, I'm getting some answers. Dengue NS1 antigen test, PCV, ultrasound scan, right? Okay. Count, we have to repeat the count here, right? So we have a count which was done the previous day with a platelet of 106, right? So we have to, as you have mentioned already, the count is important as well as PCV is important, right? So hematocrit here is 52, platelet count 33,000, right? So your diagnosis is confirmed, right? So the initial hematocrit was 39 and it has gone up to 52, right? And platelets was 106,000, it has dropped down to 33,000. So the diagnosis is DHF. Dengue NS1 antigen may or may not be positive here, so that's not that important here. But the most important things are the PCV and the platelet count, and you can do ultrasound scan if you have any node ultrasound scan, right? So it's short fluid in the hepatorenal pouch and mild pleural effusion with gallbladder wall edema and PCF, right? This patient's NS1 was positive, right? So ultimately, what you have to do is you have to manage this as dengue, DHF, right? So you have to give fluids, right? So it's very important to give fluids here and manage it as DHF. So this is an actual case. So we had to manage him as DHF, then he recovered without much problem, right? So you have to, the important thing here is you have to consider other diagnoses as well. So the case number 4, an adult patient with COVID pneumonia admitted with respiratory distress and he was started on oxygen by cylinder at 5 liters per minute. You have 2 full jumbo cylinders, each containing 7,200 liters of oxygen when completely full. How many jumbo cylinders are required for this patient to continue oxygen therapy at 5 liters per minute for 24 hours? Anybody wants to answer? Can somebody calculate and see? Okay, I got one answer saying 1 cylinder. Yes. So 5 liters per minute, right? 5 liters per minute means per hour. So 5 into 60, that means 300 liters per minute, right? So for 24 hours, you need 300 into 24, 7,200. So one cylinder contains 7,200 liters. So you need one complete cylinder to give this patient oxygen for 24 hours, right? After 24 hours, you have to escalate his oxygen therapy to 7 liters per minute. How long will the remaining cylinder last? Now you have finished 1 cylinder, so you have another 1 cylinder in your ward. So you have to increase the patient's oxygen demand has gone up. So you have to increase the, escalate the oxygen therapy to 7 liters per minute. So how long will this remaining cylinder last? Can somebody answer? So you have to calculate these things. Otherwise, it's difficult. You don't know how long the patient can be kept in the ward with your resources. So it's very important. Okay, I got one answer saying 17 hours. Yes, very good. So 7 liters per minute means 420 liters per hour. So it's like 17 hours, right? So good. Then we'll move on to the next case. You are treating for a 40-year-old patient for COVID pneumonia with oxygen 8 liters per minute. A HRCT with CTPA planned and to be done at nearest district general hospital. It will take about 1 hour to reach the destination, and the estimated time for the scan is 1.5 hours. You are planning to bring the patient back after the scan. So you have to calculate the time as well. So it will take about 1 hour to go there and 1 hour to come back, and you have to stay there for 1.5 hours, right? So the ward nurse connected the patient to a portable oxygen cylinder which has the capacity of 1200 liters, right? What are the things you want to check before starting transportation of this patient? What are the important things? Okay, one thing is you have to check whether the oxygen amount is also you have to calculate, how many cylinders you have to take, and what are the other important things you have to check. So, yes, you can answer now. Okay, I'm getting answers. Emergency drugs and emergency equipment, yes. Anything else? Okay, RV devices. Two portable oxygen cylinders. Now patient is already on 8 liters of oxygen, right? So you have to take the patient with that amount of oxygen. Okay. So what we have to do is, right? We have to contact the radiology department and see whether everything is okay, right? Yes, somebody has answered that question saying that whether the receiving end is ready. Yes, it's very, very important, because otherwise you may be taking the patient there with your oxygen, and then what happens, patient will be kept there for a long period, and they may be doing another emergency scan or something. So you have to first contact them and see whether that end is ready, right? And you have to exclude allergy and asthma. Now we are going to do a CTPA. CTPA means you have to give contrast, right? So you have to check with that and pre-medicate if needed. And you have to keep the patient for fasting for 4 hours. And investigations, you have to check whether everything is ready. Creatinine is important because you are going to give contrast for this patient. And as we have mentioned earlier, adequate oxygen, right? So 480 liters per hour should go. 3.5 hours you need 1680 liters, right? So one cylinder may not be adequate, so you have to take another cylinder as well, right? And when you are taking a cylinder, oxygen cylinder, as you know, there's a regulator connected to the cylinder, right? So when you have now in a moving vehicle, it's very difficult to disconnect the regulator and connect it to the new cylinder. So what you have to do is you have to take another separate regulator connected to the additional cylinder, right? So then what you have to do is just to connect the tube only, right? So that is important. And you have to check whether both cylinders are full, right? And you have to take the equipment, cardiac monitor, pulse oximeter, right? And emergency drugs like adrenaline, atropine, midazolam, suxamethonium, right? Penagan, hydrocortisone, saline, IV set, syringes, ambu bags, laryngoscope and tubes for intubation. In if in case we may have to, like if you have to intubate this patient, and plasters, suckers and tube, right? And then you have to check your staff is all right and they should be in full PPE, right? Okay, so we'll move on to the next case, the last case. This patient is a 68-year-old COVID positive lady, is receiving care at the treatment center. So she's a 68-year-old COVID positive lady in the treatment center. She was otherwise well on admission apart from mild headache, cough and loss of appetite, right? So she had mild headache, cough and loss of appetite on admission. So she's a non-patient with type 2 diabetes, hypertension for 5 years, and she received her drug pack via post over the last 1 year from a regular clinic. She didn't attend the clinic because due to this COVID situation. So she was she received her drug pack via post. So today is the 7th day of her hospital stay. So she got admitted 7 days before, right? Basically 68-year-old lady with diabetes, hypertension, and she was all right on admission. So this is the 7th day of illness. In your morning shift, you notice that the patient is not getting up from the bed and has passed urine on the bed, right? So the complaint you got from your nurse that patient is not getting up from the bed. You recall that she has developed fever since last evening and has refused food yesterday. She has also requested for a bed closer to the washroom the previous night, even though it has not been accommodated as there were no vacant beds. The patient is now ill-looking and tachypneic. She has been a widower since 2 years, presently lives in an elderly home. Right, so shall I go through the history again? It's a bit of a long history. So 68-year-old COVID positive lady, right? And she, on admission 7 days back, she was all right, mild headache, cough and loss of appetite. And she's a non-patient with diabetes, hypertension for 5 years. And she received her drug from the usual clinic, and this is the 7th day of the illness, and the morning she was not getting up from the bed, and she developed fever the previous evening, and she has refused food the previous day, and she requested for a bed closer to the washroom previous night. So she, when you see her, she's ill-looking and tachypneic from the distance, right? And she has been a widower since 2 years and presently lives in an elderly home. So what are the other things that you will look for in this patient before you enter the ward, right? So you have not still entered the ward. So what are the things you are going to, now we are, like we'll say, you are seeing this patient from the window, right? And what are the other things you will look for before you enter the ward? What are the important things? Can you please answer? Or you can put your answers into the chat box. Yes, somebody has said vitals, yes, but you have to go near the patient to check for vitals. Respiratory rate, yes, you can see it from the distance, right, before you enter the ward, yeah. Anything else? Okay, SpO2, yes, but if patient is already on a monitor, yes, otherwise you have to go near the patient. Okay, yes, you have to check the BHT overall appearance, yes. So the nurse says the patient is not getting up, right? So what you have to do is you have to check whether the patient is conscious or not, right? So not getting up does not mean whether the patient is unconscious or not, right? So you can talk to the patient, call the patient and see whether this patient is responding or not, right? And you have to, as somebody mentioned in the chat box, you have to get the patient's BHT and check what is the last CBS, right? Because she's a diabetic patient on treatment, right? And we can see the last monitoring chart whether this patient's saturation was all right because patient is tachypnic, right? So whether her saturation is okay. And then we can ask whether she has taken the drugs, right? And there are patients close by, so you can ask from the other patients whether she took her food or whether she has taken her drugs and whether there's any evidence of her feet, right? And she has requested a bed close to the washroom. Why? Right? That is again very important. It may be, she may be having polyuria, so if she wants to go to the washroom several times, so that may be one reason. Or it can be due to shortness of breath, right? So she may not appear dyspneic at rest, but when she walks to the toilet, what happens? She gets dyspneic, so that may be one reason why she requested a bed close to the washroom. So list out the preparations that you make before you enter the ward. Now before you enter the ward, what are the things you should take with you before you enter? Now when you are going into a COVID ward for something, right, you can't come out and go back and come out and go back. So you have to prepare and go, right? So you have to do everything and come out, right? Because you can't go and come back, not like other patients, right? So what are the things you should take with you and what are the preparations you have to make before you enter the ward? So can somebody answer? Okay, Ppes. Okay. Glucometer, yes, very good. You have to check the blood sugar, yes. And you have to take equipments to take blood for investigations, yes. Okay, emergency drugs with resuscitation trolley, yes. Yes, you have to check blood pressure, so BP apparatus you have to take, or you can do it with your monitor if you have a monitor there. Yes, patient is tachypnic, so you have to take oxygen with you. So first thing, PPE, right? Yes, somebody has mentioned about equipment to catheterize. Yes, very good, because patient has passed urine on the bed, right? So infection control, yes, PP is needed. That is first. When you are going in, you have to check whether you have done your PP, right? And you are all right, right? And you can't go alone and do all these things, right? So you need the helper here, right? So you can't you may have to do a lot of things here because patient may be quite ill, right? And patient may be like you may have to catheterize the patient, you may have to change her clothes, so a lot of things you have to do, right? So you have to take a helper with you, you can't go alone, right? And the helper also should be in full PPE if that one is going in. And emergency medicines you have to take, you don't know what are you going to deal with here, right? So you have to take cannulas, oxygen cylinder, mask, oxygen mask, right? Normal saline, dextrose, so it can be anything, it can be anything, right? And you have to take the catheter and catheter pack as well. And you have to take the glucometer with strips, and you have to take the torch. You may have to see the pupils, right? And you have to take label bottles for investigations, right? So otherwise you can't give the bottles out to label again. So you have to label the bottles and take it in. And you can take the cardiac monitor or pulse oximeter with you and some bed linens to change. So what is your differential diagnosis here?
Recording in progress.
What do you think that this patient is having? Okay, somebody has mentioned sepsis, okay. Anything else? So hypoglycemia, good. That's good. Hypoglycemia. Anything else? Okay, hypoxia, AKI, hyperglycemia. Yes, again. That is again very good. Okay, honk, yes. Okay, stroke, yes. Right. So a lot of differential diagnosis is coming, yes. Right. So hypoglycemia, DK, HHS, so those things have to be considered because this patient is a diabetic patient who was on oral drugs, and so hypoglycemia is a possibility because she has refused her food as well, right? So probably she has not taken food and she has taken her drugs, so she can get hypoglycemia. DK or HHS again is a possibility, right? DK and HHS is a possibility. And COVID pneumonia, yes, again, it can, like, patient is tachypnic, so COVID pneumonia is a possibility. Sepsis, yes. Stroke, yes, right? Stroke, MI, because they can get strokes, MI, thrombotic events are common, right? Hyponatremia, right? Elderly person who is the conscious level altered, right? Fits and psychological things also have to be considered because this patient is a widower and living in an elderly home, so social issues also can be there. Then list the tests that you would like to perform on this patient following your clinical examination. So what are the tests you would like to perform? Okay, CBS, yes. Serum apply, CCG, yes. Okay, blood gas, yes. Creatinine, okay, NCCT, X-ray, yes. Yes, okay. So CBS, yes. Count, creatinine, AST, LT, electrolytes. Cultures, again, very important, blood and urine cultures, CRP, blood gas, yes. ECG, X-ray, NCCT brain, so those things are important. Yes. Do you think that you would have acted differently when this patient requested for a bed closer to the washroom in the previous previous night? If so, how you would have acted alternatively? So this is very important. Right? When you have a patient who is requesting for a bed closer to the washroom, right? Yes, you have to find why, right? So that is very important, because it can be either due to SOB or it can be due to polyuria, right? So if it is due to polyuria, then you would have checked the blood sugars, and if patient is complaining of SOB on exertion, then you could have done an X-ray and check whether the patient is having pneumonia, and you could have actually you can do much, right? So if you get a request like this, especially in a patient who is having COVID, right? You have to see why, and you can prevent this type of things if you take precautions and if you act quickly rather than waiting till the last moment. So in COVID wards, sometimes there's nobody inside the ward 24 hours. You will be going for your routine round, and then nurses will be going 2 or 3 times per day and check the saturation and all these things. But not like in other wards. Other wards, of course, non-COVID wards, you will be there 24 hours. But here, of course, you may be going near the patient and seeing the patient. Then, of course, you may be coming out, and because of that, you have to be more careful, right? So these unexpected things can happen, right? So always if there's a complaint from the patient side, you have to see why and check for reasons and act accordingly. Okay, I'm going to finish here. So any questions you want to ask? Have you got any questions? Okay, right. So as there are no questions, so thank you very much for joining our session and wish you all the best.